Doctor, we are live. Good evening, doctors. We are very pleased to welcome you to the talk on FAQs on Ovarian Cysts by the Association of Obstetricians and Gynecologists of Delhi. Today, the host for the evening is Dr. Ankita Srivatsava. Dr. Ankita Srivatsava is presently a clinical assistant at the Institute of Obstetrics and Gynecology in Sri Gangaram Hospital, New Delhi. She has been trained in micro-invasive surgery and is also an observer in gynec oncology at Rajiv Gandhi Cancer Hospital, New Delhi. She has been a gold medalist medical student and has been awarded the Youngest Delegate Gynecologist Award. At present, she is the web editor of AOGD and also the health advisor and columnist for various newspapers and magazines in India and Dubai. She has been actively working with multiple NGOs and social foundations and has also presented papers at various national and international journals. Welcome over to you, Dr. Ankita Srivatsava.
Thank you. Good evening, everybody. I welcome you all on behalf of AOGD here today. We are discussing the frequently asked questions on ovarian cysts. I take the privilege to welcome our esteemed judges, Dr. Kanika Jain. She is extremely enthusiastic and graceful. Ma'am is member Endometriosis Committee, member Gynae Endoscopy Committee. She is past Joint Secretary NARCHI, past Secretary GRIPMA, past Organizing Joint Secretary AICOG as well as NARCHI. Ma'am is currently working as a senior consultant in robotic surgery, minimal invasive surgery at Sir Gangaram Hospital and is Vice President AOGT. Welcome, Dr. Kanika Jain. I also welcome Dr. Professor Mamta Dagar. Ma'am is a dynamic and energetic teacher. She's a senior consultant and professor GRIPMA, Institute of Obs and Gynae, Sir Gangaram Hospital. She's a secretary Association of Obstetric and Gynecology 2020 and 21 and member representative RCOG. She's treasurer ISCCP with areas of interest in high-risk pregnancy, preventive oncology, gynae endoscopy as well as robotic surgery. Dr. Mamta Dagar. I request the chairpersons to welcome the speakers.
Yeah, thank you, Ankita, for the nice introduction. It's my privilege and honor to introduce the speaker of the day, who is none other than Dr. Mala Srivastav, who is known to everyone. Dr. Mala Srivastav, she is President AOGD, and she's a senior consultant and professor Gripmer at Sir Gangaram Hospital, Delhi. She's a gynae endoscopy and robotic surgeon, and her areas of interest include gynae oncology, gynae endoscopy and robotic surgery. And you can see there are several laurels to her credit, and she has numerous publications and numerous positions to her credit. So without further ado, I will hand over to Dr. Mala for further proceedings and to proceed on to the FAQs on ovarian cysts. Over to you, Dr. Mala.
Thanks, Dr. Mamta. May I have the screen share? Today, I'm going to speak on frequently asked questions on ovarian cyst. Next, ovarian cyst is a new growth from the ovary. Either this growth is fluid-filled or tissue-filled. And ovarian cyst is not rare. It is quite common. It can vary between 8 to 18%, both among premenopausal as well as postmenopausal patients. But most of these ovarian cysts are not cancerous, and most of them will go away on their own. Yet, there are variety of ovarian cysts which can be cancerous and we should know how to deal with them. Next.
Thank you, doctor. So what are the common types of cysts?
Basically, if you talk scientifically, there are major three types of cyst: endothelial ovarian tumors, then there is a sex cord stromal tumors, and there are germ cell tumors. But when we talk about the common types of the cyst, most common is functional cyst. Then comes the teratoma, cyst adenomas, endometriomas, as well as the ovarian cancer. Now, the functional cysts are the most common types of the ovarian cyst. They usually have no symptoms and they go away on their own without any treatment within a span of 6 to 8 weeks. Now, teratoma are a special type of cyst because they have three types of lining from which the tumor grows. There is endothelial lining, there is epithelial lining, there is mesothelial linings. So this kind of ovarian cyst may have tooth, may have skin, may have sebaceous cyst, may have secretions of the sebaceous cyst, as well as hair, tuft of hairs growing inside. Teratoma are known to undergo torsions. So they are very suspicious kind of tumors, though most of them are non-cancerous. Only a fraction of them will be cancerous. But whenever we see a patient with teratoma, we always advise them to undergo surgical intervention. And there is no role of conservative management in cases of ovarian cyst, which is supposed to be teratoma. Now, cyst adenoma, they can be either benign, that means non-cancerous, or they can be cancerous also. Endometrioma is a special type of ovarian cyst, and they are having special nature, special symptoms, and they also require special type of management and treatment as well. And of course, there are a segment of patients who will be having ovarian cancer or ovarian malignancy.
So the next question comes, what are the symptoms of ovarian cysts?
See, basically, some of the cysts may be asymptomatic. That means they may be present, but they may not cause any problem to the patient. So they are known as asymptomatic patients. Most of the patients will come with non-specific symptoms. The non-specific symptoms can be abdominal distension, loss of appetite, abdominal bloating, dyspepsia, etc. But some of the patients will definitely have abdominal pain. They may be having dull or sharp aching pain throughout the abdomen, or they may be having pain while doing some activities. Larger cyst or medium cyst can undergo twisting. Especially teratomas are known to undergo twist. And whenever the ovarian cyst twist, they cause severe pain that comes suddenly. Sometimes the cyst may also bleed inside, and then they can cause severe and sudden pain. Sometimes the cyst can rupture. Then also they can cause severe pain. And some postmenopausal patients may also have postmenopausal bleeding, especially in cases of granulosa cell tumor, because this type of ovarian cyst, they produce hormone like estrogens. So these hormones will have effect on the uterus, and the uterus may start bleeding. Some patients will have rectal symptoms, and some patients will have urinary symptoms like urinary frequency and difficulty in passing urine. But definitely, most of the patients who are having ovarian cyst may be asymptomatic as well.
How do we diagnose such ovarian cysts?
See, basically, when a patient comes to the doctor with some complaint, then we have to take a proper history of the patient. Now, if the patient gives history of ovarian cancer in her mother, Masi, of first degree relative, cousin, sister, etc., then we have to be very careful about them. Or even a family history of colorectal cancer, endometrial cancer, ovarian cancer, breast cancer. Now, because these cancers are related to each other, and if they have a family history, there is a strong suspicion that this patient may also be having some kind of problem with their ovaries as well. And besides, giving a history, proper history, then also we have to think of special general examination, In the history, of course, we'll have to also say whether they are having any symptoms of dyspepsia, loss of appetite, weight loss, because all these history will point towards cancer of the ovary. Then once taking the detailed history of the patient, then we can go for clinical examination. Now in clinical examination, we have to see what is the patient, whether she has lost weight, whether there's a lymph node which is palpable, whether per abdomen any mass is palpable, or there is any other scar, previous surgery, and per vaginal examination, which all the gynecologists do, they also can see the size of the uterus, the adnexa, and any other pathology which they can see. Basically, once after doing the clinical examination, after the history, it's the ultrasound examination, which also guides us in the diagnosis of ovarian cyst. Classically, transvaginal ultrasonography is a valuable tool in the initial evaluation of an adnexal mass. But transabdominal ultrasound as well as transvaginal sonography, both are complementary to each other. And whenever an ultrasonography or pelvic ultrasonography is done, both transabdominal as well as transvaginal sonography should be done together, never in isolation. Now, functional ovarian cysts, as we say, are usually unilateral, one-sided, unilocular. That means they have just one cavity, thin-walled, and usually they measure less than 5 centimeters in diameter. If there is a solid component in any of the cysts, then we have to think and raise a suspicion of malignancy in that particular sonography.
So what do you reckon are the important differential diagnoses in the cysts?
Whenever we are getting a case of adnexal mass and we are thinking of ovarian cyst, irrespective of the size, one of the important differential diagnoses is fibroid uterus, adenomyosis. Then there can be chronic ectopic as well as the teomasses, which can also be present in some cases. Then when we think of fibroid uterus, normally ovarian cysts are cystic, but fibroid uterus are solid tumors which are arising from the uterus, and there is no gap between the fibroid uterus as well as the fibroid and the uterus. Whenever we move the uterus, the fibroid also moves. The fibroids can be multiple, they can be single, they can be bossulated, they can be uniform, and of course, ultimately the ultrasound guides us in the diagnosis.
So you've talked about the importance of ultrasound. What are the sonographic characteristics of ovarian malignancy?
Ultrasound is a very good modality for diagnosing an ovarian cyst and giving us an idea whether this is a cancerous cyst or whether it's a non-cancerous cyst. Now, if there is a presence of solid component, nodular, papillary solid component, and if there is a presence of septations, which are thick, more than 2 to 3 millimeter, if there are bilateral cysts, if there is a presence of ascites, if there is a presence of peritoneal masses, or if there is a presence of enlarged lymph nodes, all these points towards cancer of the ovary. Unilocal cyst with a single less than 3 millimeter thin septum may be a part of simple ovarian cyst, but rest, all these features, they point towards cancer of the ovary, and we have to become very suspicious about them.
So doctor, what do you suggest if the ultrasound features are not conclusive?
See, basically, if the ultrasound features are not conclusive, then we have to take the help of the other imaging modalities. Other imaging modalities are MRI, CT, or PET-CT. And they are helpful in diagnosing the cases, whether it's a pelvic mass, adnexal mass, mass arising from the uterus, mass arising from the ovary, or the surrounding structures like bowel, lymph nodes, or bony structures. So sometimes when the ultrasound is not conclusive, then we have to take the help of the other imaging modalities to prove that it is an ovarian cyst and whether it is a non-cancerous or cancerous ovarian cyst.
How do we support the ovarian cyst diagnosis?
See, when we are thinking of ovarian cyst, we are also talking about tumor markers. These tumor markers are the tests which are done from the blood. Now, tumor markers are not diagnostic, but they help in prognosis. They also help in characterizing of an ovarian mass. For example, we treat an ovarian cyst. Before the treatment, we take a CA-125 value. And after the treatment, when we do CA-125, it should be less. And then, especially in ovarian cancers, CA-125 level is seen to whether to see the effect of the treatment or not, and long-term effect of the treatment modality that we have done. Just to explain in simple terms, CA-125 is elevated in 80% of women with ovarian cancer. Although ovarian cancer of epithelial origin, although 50% of early ovarian disease may have normal values. But CA-125 is also increased in patients with other conditions. For example, endometriosis, pelvic infection, tuberculosis, fibroids, diverticulitis, inflammatory bowel disease, and hepatic dysfunction. Now, when we talk of CA-125 and we talk of treatment, suppose we are treating a patient of ovarian endometriosis and we are taking the levels of CA-125. Now we want to see the effect of our treatment on ovarian endometriosis. We do a serial CA-125 to see whether the levels are rising, whether levels are coming down. That is how we prognosticate our management. Similarly, when we are treating a case of CA ovaries, after surgery, after chemotherapy, then we prognosticate or see our effect of the treatment by seeing the levels of CA-125. If after the surgery and after the chemotherapy, the CA-125 levels come down to normal, and during the follow-up, maybe after 2 years, after 3 years, it again starts rising, then it gives us a clue that the patient is having a recurrence of CA ovary. That is how we prognosticate our management of cancer ovary with the levels of CA-125. And here lies the importance of these tumor markers, because they are not diagnostic, but they are prognostic, and they help us to know how our management is affecting the patient and the disease.
Right. Thank you. The next frequently asked question is, how can germ cell tumors be diagnosed?
So ovarian germ cell tumors are more prevalent in women under the age of 40. So sometimes additional markers are required. Now, for alpha fetoprotein is suggestive of yolk sac tumor. LDH is suggestive of dysgerminoma. Inhibin is suggestive of granulosa cell tumor. Beta HCG is suggestive of non-gestational ovarian choriocarcinoma. So these tumor markers are done before the surgery, but definitely surgery has to be done, because these tumors can be diagnosed only after histopathological examination. The tumor markers are not enough to give a diagnosis, but definitely before doing any surgical intervention, if we find that these tumor markers are raised, we have a suspicion or we make a provisional diagnosis of these tumors. Because once before the surgery, we have to have a roadmap in our mind that what we are heading for, what we'll encounter during the surgery, what will be our plan of management during the surgery. So these tumor markers, they help us to make a planning for the surgery on the table. And of course, after the surgery, these tumor markers, they help us in prognosticating the management.
Are there any additional tumor markers?
Yeah, because the additional tumor markers sometimes required. And this is because there is a possibility that the pelvic mass is representing a metastasis from a separate primary cancer. Suppose the patient is having primary colorectal cancer. So in that case, CEA will be raised. Suppose a patient is having colorectal or pancreatic primary cancer, in those patients, CA-19-9 will be raised. And if there is a suspected breast primary, then CA-153 will be raised. Because whenever we are planning any surgical intervention for any patient, we should know what is our provisional diagnosis, because we cannot hit around the bush. We should know what surgery we are planning, what management we are planning for the patient, so that the patient gets the perfect management and perfect surgery.
How do we go about the treatment of the ovarian cysts?
There are several treatment options for the cyst. If it's a simple cyst, we can just wait and watch. But if the cyst is large enough, causing symptoms, then definitely surgery has to be done.
Another question commonly asked is, what is RMI?
Yes, it's a very good question. See, RMI is risk of malignancy index, and it should be used to select those women at greater risk of cancer. Because when, as I told you, before doing any surgery, we should know what we are heading for. Using RMI as a cutoff of 200, which has a sensitivity of 70% and specificity of 90%, we can get a suspicion of cancer or malignancy in that particular patient. There's another IOTA, that is International Ovarian Tumor Analysis Classification, which can also help us to diagnose whether this particular tumor is benign or cancerous or malignancy. Women at high risk of malignancy with RMI more than 200 gives us clinical suspicion. So these patients should be discussed with the gynecological oncologist and at the gynecological oncology multidisciplinary team meeting. These should not be taken up by a person who is not very confident for handling gynecological cancers.
How do we calculate the RMI?
See, what is RMI? RMI is a clinical prediction based on ultrasound, CA125, and menopausal status of the patient. RMI is U into M into CA125 value in numbers. So the ultrasound score is calculated by awarding 1 point for each of the following characteristics. Whether it is a multilocular cyst, whether there's evidence of solid areas, whether there is a presence of ascites, evidence of metastasis, bilateral lesion. U is 0 if none of the above features are present. U is 1 for ultrasound score of 1. U is 3 for ultrasound score of more than 2. CA125 exact value is written in numbers. Menopausal status M is 1 if patient is premenopausal, or M3 if postmenopausal.
Okay. So what are the simple ultrasound rules?
See, the simple ultrasound rule says we want to diagnose whether it's a normal ovary, functional ovary. Whether it's normal ovary, functional cyst, benign tumor, borderline tumor, or invasive tumor. So ultrasound reports categorizing adnexal masses. It helps with patient referral pathways, helps to reduce unnecessary patient anxiety.
What are the benign features?
So the benign features, according to IOTA, we have to see that using IOTA, a mass is classified as benign if at least one B feature is present and no M feature is present. So B1 is unilocular cyst. B2 is presence of solid component with largest diameter less than 7 millimeter. B3 presence of acoustic shadow. B4 normal multilocular tumor with largest diameter less than 10 centimeter. B5 no blood flow.
And what are the malignant features?
Using IOTA rules, a mass is classified as malignant if at least one M feature is present and no B features are present. M1 is irregular solid tumor. M2 presence of ascites. M3 at least 4 papillary structures are present. M4 irregular multilocular solid tumor with largest diameter more than 10 centimeter. And M5 very strong blood flow. So the rule 1 is if one or more M features are present in the absence of B features, the mass is classified as malignant. Rule 2, if one or more B features are present in the absence of M features, the mass is classified as benign. Rule 3, if both M feature and B features are present, or if no B feature or M features are present, the result is inconclusive and a second stage test is recommended. That means we have to do either MRI, PET CT, or
How should we manage these cysts?
See, now every case has to be individualized. Now, depending on a provisional diagnosis, we have to map out the management of our patients. Asymptomatic ovarian cyst will require maybe no action, observation, or surgery, depending on the specific features. The potential risk of surgical intervention needs to be balanced against the risk of malignancy attributable to each and every individual case. No further action is required if in premenopausal simple ovarian cyst less than 5 centimeter, because these cysts are almost certainly benign. Postmenopausal simple ovarian cyst less than 1 centimeter, also no further action is required if CA125 is normal.
What is the conservative approach in here?
When we talk of conservative approach, we have to see whether the patient is having functional ovarian cyst or not. Now, functional ovarian cyst never occurs in postmenopausal women. Functional ovarian cyst always occur in women of reproductive age group. Now, premenopausal patients who are having simple cyst less than 7 centimeters with no features of malignancy, then the risk of cancer in such patients will be less than 1%. Postmenopausal simple cyst less than 1 centimeter with no other features of cancer and normal CA125, here also the risk of cancer is less than 1%. And if these patients are asymptomatic, we need not go for surgery. We can do conservative management of these patients. And of course, we have to weigh the risk of surgery and the benefits of cyst removal. Sometimes when you counsel the patient says, no, doctor, I don't want to have any surgery. Please keep me under conservative management. In that case, also, according to the patient preference, you can do conservative management of the patient after counseling the patient completely.
How should we follow up these patients who are conservatively managed?
When we talk of conservative management of the patient in premenopausal simple cyst less than 5 centimeter, no further investigation is required because there is no significant risk of cancer. Now, patient between 5 to 7 centimeter, over 50% of ovarian cysts detected in premenopausal women will be functional. And 90% of these functional cysts will resolve within 2 months. Of course, we have to do CA125 and see whether it is normal or not. And we have to repeat ultrasound scan at the end of 6 months. If we see the size is unchanged, then in that case also, we have to keep these patients under regular follow-up. But mostly functional cysts after 2 months or 3 months, they will decrease in the size and no further maybe investigation may be required in future. But if the cyst remains unchanged, an annual scan has to be done. And if the CA125 is rising or the size is increasing or there are features of complexity, then in that case also, we may have to think about the surgical intervention in these patients. Some of the clinicians, they are fond of giving combined oral contraceptive pills, but literature does not support the benefit of giving oral contraceptive pills for the treatment of functional ovarian cyst. However, they have seen that progesterone methods like POP or injectable progesterones, if they are stopped, maybe sometimes the functional cysts, they do improve.
What is the approach in postmenopausal women?
Now, in the postmenopausal women, we have to be really very careful. Ultrasound and CA125 should be performed every 6 months till the cyst resolved. Unless the patient's cyst is more than 1 centimeter, we have to be very careful. If there is no change in the size of the cyst after 1 year of follow-up, then the patient may be counseled and may be called for annual checkup instead of 6 monthly checkup. But asymptomatic, simple, unilateral ovarian cyst less than 1 centimeter in diameter have a low risk of malignancy less than 1%. But overall risk of malignancy, even in simple cyst in postmenopausal women, regardless of size, sometimes may be up to 10%. So you have to be very careful in the patients who are postmenopausal and who are having ovarian cyst. Any ovarian cyst in the postmenopausal women more than the size of 1 centimeter should be carefully handled. and we should do the CA-125 level, and we should weigh the benefit of surgery versus risk in these patients.
When would you recommend surgery?
When the cyst size does not decrease, it keeps on increasing, CA-125 keeps on increasing, then in that case, we have to think of surgical intervention in these patients. Because conservative management may be appropriate in selective cases, but if the size of the nature of the cyst is changing, simple cyst becoming complex, or the size of the cyst is rapidly increasing, CA-125 rapidly increasing, then we have to think of surgical intervention. Laparoscopic approach can be given to these patients if we presume it is a benign mass in preference to the laparotomy. But larger cysts may still require laparotomy depending on the size, type of the approach to the surgery, and of course, the surgical skill of the treating physician.
What should we do in complex ovarian cysts?
See, the complex ovarian cyst should demand surgical intervention unless we think it's an hemorrhagic cyst or it's a corpus luteum. Functional cyst, as I told you, does not occur in the menopausal patients. Again, postmenopausal simple cysts who are more than 5 centimeter, the risk of malignancy can be between 2 to 9%. Premenopausal simple cyst more than 7 centimeter, there's a concern regarding the assessment of the cyst wall beyond 7 centimeter. So we should do MRI and we should offer these patients surgical intervention. Of course, we give surgical intervention if the patient is symptomatic. Even if the size is between 5 to 7 centimeter, she's having pain, then we should offer them surgical intervention. And of course, whenever we have a suspicion of cancer, high history of family history of malignancy, even a small size of cyst, we should offer them surgical intervention and do the histopathology of the cyst and then counsel the patient.
What surgery would you recommend?
See, if we think it's a benign ovarian cyst, then we can go for surgical laparoscopic approach and just do the removal of the cyst. But if the patient is postmenopausal, then in that case, there is no role in removing just the cyst. We have to offer them salpingo-oophorectomy. That means removal of the ovary together with the removal of the tubes. Now, patients should be counseled preoperatively if there are features of malignancy, cancer during laparoscopy. You put in a laparoscope, you think that the patient is having cancer, then the procedure may have to be abandoned, and at the same sitting, we can go for laparotomy under the oncology team, or we can counsel the patient and we can do proper surgery at a later date, depending on the situation, depending on the availability of the oncology team, depending on the counseling that you have done to the patient. Ovarian cystectomy and preservation of ovarian tissue is preferred in patients who having benign disease and who wish to retain their fertility.
What are the special situations in case of an ovarian cyst?
Now, when we're suspecting endometrioma, then they have to be dealt with differently. Endometriomas can appear complex on ultrasound and can be associated with increased levels of CA-125. MRI can be useful when the diagnosis is unclear using ultrasound. Malignant transformation occurs only in 1%, with the majority occurring in patients whose size is more than 9 centimeter and in women over 45 years of age. Although it is recommended that even if the patient is having endometrioma or endometriosis, if the size of the endometriosis is more than 3 centimeter, the surgical intervention should be done and histopathology should be obtained in these patients. Endometriomas can be managed within a spectrum of treatment with medicines, other modalities, and whenever in an endometrioma, solid elements they appear, they should raise concern about malignancy. A special situation is pregnancy with ovarian cyst. Incidence of ovarian cyst in pregnancy, 30% in first trimester, of which 90% represents corpus luteum of pregnancy, and they will resolve spontaneously. And of course, if there is an ovarian cyst with pregnancy, majority can be managed by conservation management.
What are the complications we can expect in ovarian cysts?
Now, sometimes even during pregnancy, These ovarian cysts can undergo torsion, rupture, hemorrhage, and less than 1% chance of malignancy. And of course, we cannot follow these patients with tumor markers because tumor markers will again be elevated in pregnancy and will be of little help to us in prognosticating the ovarian cyst during pregnancy.
What are the indications for surgery in pregnancy?
Sometimes, even during the pregnancy, we'll have to undergo surgical intervention. When there is a complex cyst with suspicion of malignancy and the size is not decreasing to the expected amount and the size may be increasing, then in that case, we have to offer surgical intervention to our patients. Symptoms of pain, torsion, rupture, or bleeding, we have to offer surgical intervention even during pregnancy. MRI may be useful when evaluating such suspicious cysts. If surgery is necessary, this can be safely performed during second trimester in experienced hands by a laparoscopic approach. But then each case has to be individualized. If there is a surgical expertise present, definitely laparoscopic approach is good for the pregnant patient. But an ovarian cyst diagnosed at time of cesarean section should be removed either by cystectomy or oophorectomy rather than aspirated. And here, a senior input is very important. Level of consultant involvement should be recommended, not at the level of senior residents, because here a senior input and experienced person has to put in their views before you do either cystectomy or salpingo-oophorectomy during cesarean section.
Can we go for conservative management in these cases?
Now, if the patient has been asymptomatic, the size is less than 10 centimeter, if the cyst has not increased in size, what size we saw at 20 weeks anomaly scan, the same size is there, maybe we can leave these patients for conservative management and follow-up ultrasound scan after 6 weeks postpartum. But here again, I will say that we have to individualize the cases. And here again, a senior input is very important. Consultant level, experienced person, they should have to make a decision whether the cyst has to be left alone or whether the cyst can be operated at the time of cesarean section or not. Patients with suspicious adnexal masses detected during pregnancy should again be discussed pre-operatively at gynecological oncology multidisciplinary team meeting. Because when we are doing cesarean section, we should know what we are heading for. If we have diagnosed these ovarian cysts at anomaly scan and they have been following the patient throughout the pregnancy and now we are planning cesarean section for these patients, so we should know what is the roadmap or planning for this patient. Besides cesarean section, are we going for cystectomy of the patient or we are going for the salpingo-oophorectomy of the patient? So this has to be properly discussed and a roadmap should be planned for these patients. It should not be a conscious decision at the table.
How do you suggest we follow up the borderline tumors?
Now, these borderline tumors are special types of tumors. Now, all the decision, suppose we have made a decision, diagnosis of borderline tumor after doing cystectomy, then in that case, we have to complete the surgery. Complete the surgery means suppose we have done cystectomy and the report has come as borderline tumor. Then we have to do staging laparotomy for these patients. We have to stage the patient. Same side salpingo-oophorectomy has to be done. Other side ovary biopsy has to be done. And then peritoneal washings has to be taken. Multiple peritoneal biopsies has to be taken. Omentectomy has to be done. And lymphadenectomy has to be done properly. Now, suppose we have done hysterectomy and then we have done bilateral salpingo-oophorectomy. So both the ovaries are already removed and it's still stage 1. Then maybe no follow-up is required because the prognosis is excellent. We have already removed both the ovaries and still depending on the CA-125 level, we may have to think whether this patient will require staging laparotomy at the second sitting and lymphadenectomy, peritoneal biopsies, washings, etc. has to be taken and not this decision has to be taken in a multidisciplinary approach by the gynecological oncologist. If only one ovary has been removed, again, if it is a stage 1, then we have to tell the patient that the risk of recurrence is approximately 40%. So again, these patients have to be counseled, and a proper staging laparotomy has to be done in a case of borderline tumor with only one ovary removed.
What are the indications for conservative management further?
Now, in the borderline tumor, we have done, suppose, unilateral salpingo-oophorectomy and the staging laparotomy has been done. Then in that case, we tell the patients, complete your family, and then we can go for hysterectomy and salpingo-oophorectomy of the other side. Again, if it is stage 2 and stage 4, then things have to be individualized. Management has to be individualized. For fertility sparing surgery, again, we have to do same-sided salpingo-oophorectomy, staging laparotomy, biopsy of the other ovary, multiple peritoneal biopsies, lymphadenectomy, peritoneal washings, and DNC. And again, we have to counsel the patient that they have to be on regular follow-up till they have completed the family. And once the family is completed, then we have to go for hysterectomy and the complete surgery of these patients.
Is there any role for aspiration of cysts?
Aspiration of cyst should never be done, because benign cyst, they will recur, malignant cyst will be upstaged. Still, once upon a time, we were doing image-guided aspiration. Now it should never be done. Image-guided tissue biopsy is done sometimes when there is a significant medical comorbidities contraindicating the surgery. The cyst is causing significant symptoms. If the cyst is aspirated also, this fluid should not be sent for cytology, as sensitivity and specificity are so poor as to render the result meaningless. Suppose we are suspecting advanced CA ovary and we think that we may not achieve good cytoreduction on the primary surgery, then in that case, we can go for image-guided tissue biopsy, so that once we have the tissue biopsy, we can plan a specific chemotherapy for these patients. Neoadjuvant chemotherapy is given, 3 cycles, followed by cytoreductive surgery, followed by remaining 3 cycles of chemotherapy. So image-guided tissue biopsy is done in only special cases when we are suspecting advanced ovarian tumors, which we think we may not be able to achieve good cytoreduction on primary surgery only.
What should we do if an ovarian cancer is suspected before surgery?
See, if we are suspecting ovarian cancer before surgery, then we have to counsel the patient that we are going to do laparotomy and proceed. Laparotomy and proceed means we give a vertical incision. As soon as we give the vertical incision, we take the peritoneal washings, and then we do inspection of the entire abdominal cavity, either clockwise or anti-clockwise fashion. We remove the ovarian cyst, send for frozen, and in the meantime, if we have counseled the patient, we can go for hysterectomy and salpingo-oophorectomy. If the patient is young, we want to preserve the uterus, then we just send the tumor for frozen section and we wait for the frozen section report before we proceed. If the frozen section says it's a cancer, then we have to proceed with hysterectomy, next-sided ovarian salpingo-oophorectomy, lymphadenectomy, omentectomy, multiple peritoneal biopsies, and if there's a mucinous tumor, then we also have to do appendicectomy of this patient. All this preoperative evaluation should be done by MRI or CECT together with tumor markers. Preoperative mammography is a good practice. Preoperative upper GI, lower GI endoscopy is also should be done as a part of the pre-op evaluation of the patient.
Thank you. This was a complete academic feast. I thank Dr. Mala for an extremely extensive coverage of all aspects of the frequently asked questions on ovarian cysts. It was a thoroughly enriching experience. Thank you. I invite the respected chairpersons to take the Q&A from the audience now.
Yes, there are a few questions in the chat box which I can see, which I will be putting to you, Dr. Mala. There are a few questions. There are not many, but a few of them are there. And the question is, this is from Dr. Just a second. The question from Dr. Nasreen Mawani, that huge ovarian cyst after hysterectomy, what is the line of treatment?
See, these patients, again, we have to do pre-op evaluation by doing CA 125, MRI, And depending on these levels, as I told you, if we are suspecting malignancy in these patients, then in that case, if the mammography has not been done, it's a good practice to do mammography also, upper GI, lower GI endoscopy, if you're suspecting malignancy. If you're suspecting it's a benign tumor, still we have to do CA-125 MRI as a minimum pre-op investigation besides the blood test. And then we have to remove these cysts. We cannot leave them behind, because if the hysterectomy has been done, we think that patient will be at least 40 plus. So patients who are having huge ovarian cyst after the age of 40 should have a surgical intervention. There's no role of conservative management in these patients.
Okay. So the next question is from Dr. Parul Parekh, that postmenopausal simple cyst with no symptoms, accidental finding needs to be operated. What is your stand on this?
See, if the patient is postmenopausal and the cyst is more than 1 centimeter, it should be investigated thoroughly. And if the patient does not want surgery, they should be kept under close follow-up. CA-125 should be done. If the size is more than 1 centimeter, maybe 3 centimeter, 5 centimeter, these patients should have their ovarian cyst removed. And salpingo-oophorectomy is a good option for them. We may not go for hysterectomy for these patients if we are still thinking that is a case of benign ovarian tumor, but still we can do laparoscopy for them. We can do only salpingo-oophorectomy for these patients. And if the report comes out to be benign, then it's fair enough. Because any ovarian cyst in postmenopausal patient, there's 2 to 9% chance of malignancy. So we should not take these patients lightly, even if the size of the tumor is small.
Yeah, so
they should undergo surgical intervention.
So the simple cyst, if they are, and either they need a very close supervision and a follow-up, or they require, salpingo-oophorectomy. If the expertise is there, laparoscopic salpingo-oophorectomy is a good option for them. Next question is from Dr. Polak Deka. Medical treatment of ovarian cyst. What do you basically want to highlight on this medical treatment of ovarian cyst?
Basically, medical treatment, there's nothing called medical treatment of ovarian cyst. If you're suspecting endometriotic cyst, only after getting a histopathology of endometriosis, there are management for endometriotic ovarian cyst. But simple ovarian cyst, there is no medical treatment. Either if it is a functional cyst, it will go away on its own. There has been trial of giving oral contraceptive pills for these patients, but then the literature does not support that the oral contraceptive pills have any role in functional ovarian cyst. These functional ovarian cysts will go away on their own in a span of 2 or 3 months. But if you think that you want to help these patients with giving something or the other, sometimes what happens, these patients are taking progesterone only pills, or they're taking injectable progesterones for contraception. If you stop these things, the functional ovarian cyst goes away on their own. So you have to counsel the patients, get their tumor markers, keep them on close follow-up, and then only you can decide whether you can give us conservative management or whether you want to do a surgical intervention for these patients.
Yeah. We have with us Dr. Kanika Jain also as chairperson. So Dr. Kanika, would you like to take further questions?
Actually, Mamta, I can't see the chat box.
I will take another next question to you, Dr. Mala. The question is from Dr. Bhopi, that what is the treatment for hemorrhagic cyst?
See, basically, hemorrhagic cyst, if it is an endometriotic cyst, we are thinking, then in that case, basically, we have to give specific treatment for endometriosis. But if the size of the endometriotic cyst or the hemorrhagic cyst is big enough, then surgical intervention is a good option. Because any hemorrhagic cyst more than 5 centimeter or 5 to 7 centimeter, then in that case, it's always better to individualize the patient and give a surgical intervention. Even if we think it's a benign condition, at least we should do cystectomy of the patient and get a histopathology of the patient, because we may be missing some malignancy in these patients.
Okay, the next question, same is from Dr. Bhopi only, that how to differentiate hemorrhagic cyst from endometriotic cyst?
See, basically, it's very difficult ultrasonographically to differentiate between hemorrhagic cyst and endometriotic cyst because both of them will appear similar. Maybe in hemorrhagic cyst, there can be just a single loculi, and hemorrhagic endometriotic cyst, there can be multiple loculi. Dr. Kanika will be able to uh, tell better about these things, but it's very difficult to differentiate ultrasonographically or by MRI to differentiate between hemorrhagic cyst and endometriotic cyst because both of them will have similar appearance, and CA125 will also be raised in both the conditions.
Yeah, Dr. Kanika, you want to add on onto this, that how to differentiate the hemorrhagic cyst from the endometriotic cyst?
Dr. Mala has very beautifully answered. I think there's just a point of difference that we can see debris and we can see hyperechoic areas in the endometriotic cyst sometimes, and the wall is thickened, very echoic. So that differentiates it from the hemorrhagic cyst usually. And plus, of course, we can do the Doppler flows, and plus the endometriotic cyst sometimes can be multiseptate. So that those are the differentiating features.
Okay, there is one question from Dr. Polak Deka that what is the role of chemotherapy? I don't know. Just this is the question from her.
Basically, if we have diagnosed the case of ovarian cancer, then ovarian cancers, depending on the stage 1C, we have to give chemotherapy to complete the management of the patient. Even after surgical intervention, even if we have done the staging laparotomy, done the complete surgery, we have to give chemotherapy to complete the treatment of the patient. That is the role of chemotherapy in ovarian cancer. Because ovarian cancer is a cancer which tends to recur. So primary treatment should be a complete treatment. That is why there is a role of staging laparotomy. That is why there is a role of following up this patient with CA125, because we have to keep a close watch on the recurrence of the patient also. Because ovarian tumors, they tend to recur. So primary treatment has to be complete. And if there's a 1C onwards, we have to give chemotherapy to complete this primary management of the ovarian cancer.
Okay, another question is there from Dr. Anusmita Gautam. She's asking, any treatment is there for ovarian cyst and fibroids also? Please tell.
See, basically, for ovarian cyst, there is a conservative management. There's actually no treatment for these patients. We have to keep them under close follow-up and follow them up with regular ultrasound and CA125. For fibroids, of course, there are treatment like ulipristol, which tends to decrease the size of the fibroid. There is also mifepristone, which we are giving. That also sometimes decrease the size of the fibroid depending on what is the starting point of the size of the fibroids. Very large fibroids will not decrease in size. Fibroids which are 3 to 4 centimeter, if we give ulipristol or maybe we give mifepristone, maybe their size can decrease to some extent. But by and large, fibroids also require surgical treatment because they are tumors, and with time they go on increasing in size, and with time they can also give symptoms to the patient.
Okay, I cannot see further questions. I think, let me just see.
I can see one question.
Yeah, there is one more question. You can take, Dr. Kanika.
Yeah, a question from Dr. Jitinder Kaur. The patient has adenomyosis with 2.8 into 2.5 centimeter unilateral hemorrhagic cyst and wants to conceive. What will be the line of management?
Now we have to see what is the size of the hemorrhagic cyst.
2.8 into 2.5.
This is perfectly almost normal size, so she can go ahead with the conception. There is no, see, if she is having problem in conceiving, then she has to take specific investigations and specific help for conception. For adenomyosis of small size and this small hemorrhagic cyst, no surgical intervention is required. And she has to go for maybe ovulation induction, tubal testing, all these investigation for infertility management, ART management. Then she has to go for that specific management. She has to just think in the line of conception, not in the line for treatment of hemorrhagic cyst.
Yeah, you're right. I think she should be given a good trial first, because adenomyosis per se with a cyst and a hemorrhagic cyst could be an endometriotic cyst, and she may have problem in conceiving. But first, we should give her at least 4 to 6 months of good trial, And if she doesn't conceive, then we should think of some assistance. Another question from Dr. Meena Kapoor. Hemorrhagic cysts have fishnet appearance on ultrasound, while endometriotic, I don't know, maybe she wanted to write something else. So that's missing. So that's all that I can see, Dr. Mamta. Dr. Meena Kapoor has written another question. Endometriotic cysts have ground glass appearance. Yeah, I missed out on that. Right. So, Dr. Mamta? Mamta?
So, yeah, I think we are cannot see any more questions in the chat box. Anything you want to add on, Kanika or Dr. Mala? You can add on to this.
I think Dr. Mala can summarize. She's beautifully explained.
Basically, we have to tell our audience that ovarian cyst is a common condition. We should not be afraid of it. Most of them will be benign. A good fraction of them will be functional cyst, which will go away on their own. Even if it is a benign tumor, nothing to worry. And if when our pre-operative evaluation, we should evaluate each and every case of ovarian cyst. And if it is an ovarian cyst is benign, we should offer them laparoscopic surgery, which is a minimally invasive surgery. And initially, we should only try to do cystectomy of the patient and then leave the patient alone and keep the patient on follow-up. But if we suspect it's a case of malignancy, then there is a lesser role of minimally invasive surgery. Ovarian cancer, we have to do laparotomy and do a justice because we have to do a good surgery, primary surgery. That is very important because once we suspect it's a case of cancer, then we have to do an open surgery, staging laparotomy, and a good complete surgery should be done in the first go. So whenever we are suspecting ovarian cancer by our RMI, by our IOTA, by all the pre-op evaluations, then we should refer these patients to specific gynecological oncology team so that the patient gets the best treatment in first go. And then a proper management can be planned for them. Nothing to worry. Ovarian cysts will remain common. They can sometimes appear during pregnancy also. And of course, again, even during pregnancy, we can manage them and nothing to be worried. And the patients can be having a proper treatment, proper guidance, and proper management for the patients.
Thank you. Over to Dr. Ankita.
Thank you, ma'am. I take extreme privilege in proposing the vote of thanks. I thank our honorable speaker, Dr. Mala Srivastav, for enlightening all of us through a thorough evaluation and explanation on the common questions surrounding the ovarian cyst. I am extremely thankful to the esteemed chairpersons, Dr. Kanika Jain and Dr. Mamta Dagar, for their invaluable time and presiding over the session so smoothly and flawlessly, with their priceless inputs and opinion. I also thank Ms. Vaishnavi and Mr. Shobit and the wonderful team Omnicurus for the digital platform and support, and an excellent workshop and excellent FAQs for an extremely important topic. Thank you very much. And I thank the audience today for listening to the session and participating with their questions and answers.